Hello, my name is Michael Lichtenberg from Arnsberg Vascular Center, Germany. I'm interventional angiologist, and today I would like to introduce you to the Tack endovascular system. We use this system in a patient with Rutherford 5 on the left side, a young 55-year-old male patient with severe diabetes for many years, also smoking and dyslipidemia. This patient was already revascularized on the left side with a stent implantation in 2017, and now he came back with a high-grade stenosis, especially of the left proximal SFA. We started first with an up and over maneuver and then wiring of the SFA, and you could see here as a first attempt a standard balloon angioplasty of the SFA, especially the distal SFA, but also within the stent and also very proximal. Of course, and we know that from many patients in our daily routine work and also from many studies, after standard balloon angioplasty and after drug-coated balloon angioplasty, we face a lot of dissections. And based on the existing TOBA trial data, we know that dissection have a significant impact on patency rate and clinical outcome for our patients. And therefore, we also analyzed here the situation, the proximal left SFA. You could see here after standard balloon angioplasty, a long dissection area, especially in the proximal SFA. And based on the existing literature, I think it is clear that we need to treat these dissections. And therefore, we decided to use the Tack endovascular system, which comes in two sizes. One for treatment of the above the knee vessels and one system for below the knee. The preparation of the system is very easy, just need to flush the system, and the system then comes over an 035 wire if you want to treat the SFA with a 6 French device. I highly recommend to use an 035 wire for stability and of course for a very adequate implantation of the stents. And here you see how the system guides very easily over the 035 wire. I highly recommend to use either roadmap, overlay technique, or to use a ruler for precise location of the dissection. The individual tacks are only 6 millimeter long, so therefore an adequate identification of the lesion is very important. The above the knee system has 6 tacks on the catheter. The below the knee system just has 4 tack stents on the system. Here you could see that we identified very precisely the individual dissections, and then we forwarded this system to the very distal dissection first and then started with the deployment. It is important that you start quite distal first with the tack and then wherever you need more proximal with the tack implantation. It's a typical pin and pull system, so you just need to open the hub and then slowly perform the typical pin and pull maneuver. Here you could see how the system nicely opens, and also the animation shows how the tack system opens adequately at that area where you want to have it. There's nearly no foreshortening or forejumping. Here the second tack is implanted and also the third. You can of course implant all the 6 tacks at the first attempt, but you can also, like we do it here, retract the system first and check the individual situation of the lesion which you treated with the tack system. For that purpose, we performed an angio here just to see where we need to implant more tack systems. You can see here that the distal dissection were already healed here with the tack stent system, but we brought the system in, and this is also a clear advantage of the Tack endovascular system. You can always bring it back and implant more tacks at the area you want to have it. You could see that we opened the fourth, fifth, and also the sixth tack here in this particular lesion. After this, it is important, of course, to post-dilate the implanted tacks. For that purpose, I used here 3 drug-coated balloons, which we inflated first in the distal SFA, mid SFA, and also within the implanted tacks. Here you could see how nicely the drug-coated balloon opens within the tacks, and I usually perform a nominal pressure inflation, so 6, 7, maximum 8 atmospheres. After this, you could see here the nice outcome, no persistent dissection in this lateral view. I highly recommend to perform different angulations to rule out persistent dissections within the treated area. As this was a Rutherford 5 patient, we then decided to perform also Btk intervention, and we decided to treat the posterior artery also in this patient. For this purpose, we used an 014 Advantage wire, and this could be easily guided into the posterior artery, as you could see here. The guide wire easily followed the posterior artery as there was no occlusion, just obstructions. And we then used a 2.5 millimeter standard balloon for revascularization, inflated to 10 atmospheres for 2 minutes. And we also know, especially after having seen the TOBA2 BTK data, that dissection below the knee are very frequent. Dissections to identify, especially below the knee, is not very easy. Therefore, I highly recommend to perform different angulations to sort out dissections. Dissection could be flow limiting. And also here in this particular posterior artery, we saw some significant dissections, especially in the proximal part. And therefore, even that they are not significantly flow limiting, but as we know that they are associated with lower patency, we decided to implant also here the Tack endovascular system to heal these proximal dissection. For that purpose, we use the 4 French below the knee system. Again, 4 tack stands mounted on the system, and it can be used just like the above the knee system. You have to bring it over the wire after flushing. So den letzten Satz nochmal. This is a 4 French system which guides easily over an 014 wire into the target lesion. And you could see here that we had no issues with bringing the system into that area between 103 and 110. And then we started with the deployment. Again here, typical pin and pull technique. So hold the system very straight, open the hub, and then retract the cover sheet. Again, you can see here also within the animation, there is no forward movement of the system. There's no forward jumping, and the system releases the individual tacks very precisely at the area of dissections. Of course, also here, post-dilatation is important. Below the knee, I usually use quite short balloon if I just need to post-dilate 1 or 2 tacks. So this is a 2.5 20 millimeter balloon just for post-dilatation. 10 atmospheres were applied here. After post-dilatation, very good flow into the lesion and very good outflow of the lesion, no persistent dissection, no slow flow. So in conclusion, the above the knee and below the knee tack stents can be used very easily, can be implanted very precisely, and offers you the possibility to treat the persistent dissection and to reach a very good patency rate over the time, especially in patients like in our patients here with critical lymphedema. Thank you very much for your attention.